The Sinai Medical Foundation Oral History Project is being conducted by the Leonard N. Simons Jewish Community Archives. My name is Michael Burke, and today's date is December 1st, 2023. I am interviewing Dr. Melvyn Rubenfire. Dr. Rubenfire, do you give permission to the Leonard N. Simons Jewish Community Archives to publish, duplicate, or otherwise use this recording for educational purposes or for use as deemed appropriate by the archives?
Yes, I do.
Good. I'm glad to hear that. So let's start at the beginning. Where were you born?
Detroit, Michigan.
Yeah. Did you live your whole life in Detroit?
100%.
100%. What inspired you to become a doctor?
That's a good question because, everybody asks the question, and my father was involved in businesses, and there was a lot of anti-Semitism when he was, and he said that you should become a professional. A lot of Jewish people are becoming lawyers, doctors, pharmacists, and whatever. So I thought of being a physician would probably be the thing I wanted. And in part it was because he respected his physician so much. Mm-hmm. The family, the doctor was important. So I was attracted to it.
I'm just curious, it's not in the questions, but what kind of anti-Semitic experiences did your dad have?
He was involved in the cash register business, used cash registers. And at the time in the early 1950s, the National Cash Register came out with an electronic cash register. And he was well known by the National Cash Register group. And he said to the Michigan representative, told him he'd like to be the distributor. And the man said, "Yeah, Harry, you're wonderful, absolutely." So he comes back a month later and he said, "Harry, I'm terribly disappointed for you. They won't take a Jewish man." So my father closed his business, put all his cash registers on my ping pong table, and called Irving Hermelin, who was in the insurance business, said, "Irving, I'm studying for the exam. Can I come into your business?" That's how it started.
So the Hermelin family...
Hermelin Rubenfire, we're dear friends,
yeah,
even now.
Where'd you go to medical school?
Wayne State.
Were there any other thoughts about going anywhere else beside Wayne State?
We couldn't afford it.
So describe your experience at Wayne State in the medical school and the kind of education that you got.
It was a better education. We who went there felt it was, and we were pretty confident it was a better education to be a physician, to be a clinical physician. We knew physicians or residents applying subsequently, met them, and they were not from University of Michigan, and they weren't as prepared as we were. Their clinical experience wasn't as good. We were taught by really wonderful clinicians who were volunteer clinicians. There wasn't a big full-time faculty. So Wayne State was an incredibly good school. We had really bright kids and brilliant teachers. They were the best of the clinicians in Detroit. And so, like the University of Michigan and the other schools, usually had a full-time faculty. And they were interested in their focused area, whereas our internal medicine doctors were really quite capable.
Any doctors particularly stood out to you in your...
We had outstanding cardiologists, neurologists. Nobody stands out except the cardiologists because they were my role models. Mm-hmm. Richard Bing was one of them.
So describe your residency for us a little bit.
So the idea that I was going to become an academic clinician was not there. When I was in medical school, I was going to go in clinical practice, and cardiology was what I wanted because my role models, and actually my father-in-law was a cardiologist, Melvyn, and so I would hear about this all the time at dinner with my wife, and this is when we were dating each other. And so leaving town to go to some academic program wasn't in my mind. Sinai was the hospital that everybody knew, and it was a very comfortable hospital because doctors were all wonderful and Jewish. So I had no question that I would stay in Detroit, become a clinician over time, and that's what it was. But the experience there was incredibly good. When I first got there, it was much better than I thought because the clinicians were fabulous. The doctors were brilliant, and they were the brilliant young students who went to undergrad schools and couldn't get into medical schools, but they did. So if they got into medical school, you would know they were brilliant, and that's what we saw. And actually, this is not part of your question in relationship to what I experienced, but when I went to work at the University of Michigan many years later, I realized that our clinicians were the best.
That's interesting and nice to hear.
Yeah.
You sort of alluded to why you thought of going into cardiology. Why don't you expand on that a little bit? You know, father-in-law aside, why you decided to go into cardiology and make that your profession?
Right. So everybody has an idea of what direction they might go in. Cardiology was very interesting because it had so many facets to it, and the academic part of it and scientific part of it, the physiology of the heart, and you could put your arms around or wrap around the heart. I never wanted to be a general practitioner. It would have been too hard to know it because I was also one of those people that needed to know everything I could know about what I was studying. And that's a weakness because it forces you to know the whole body and to try to take care of patients with that. So family physicians, that was out. And the idea of specializing in cardiology because my father-in-law was a role model was easy because I heard about it, and then I knew that in medical school I was very capable of understanding that.
So describe your experience and how you came to decide to go to Sinai Hospital.
So it was easy to. You're talking about as a resident or as a practicing physician?
Both.
So my residency, there was no question because it was the best training program in town for a general practitioner or a specialist like I was not interested in an academic career. And there was just no question that's where you'd want to be. It was also comfortable. The Jewish hospital, the Jewish doctors, Jewish colleagues, anti-Semitism was there when I was young and in medical school. Although we didn't feel it in medical school because 20% of the class was Jewish and you had a lot of colleagues. But we knew it was there. Racism was definitely there. So when I got to Sinai, it was a wonderful training program. And the idea of going into cardiology was in my mind. We had a very good academic full-time faculty at the time in internal medicine. There were two people. The chairman of medicine was brilliant, had been through the Harvard system, and was an excellent clinician himself. And he was really academically inclined. He wasn't writing papers, but he knew the literature incredibly. So that was a role model that I wanted to follow. And then there was a few educators who were wonderful. And while I was there, I just enjoyed it. I enjoyed every part of Sinai and the residency and the idea that each of our departments was like an academic center. As a resident, what you wanted to be sure of is you were taking good care of your patients. And that was the truth with all of the physicians. And it was easy to say we were doing that because pathology was wonderful. Anesthesia was wonderful. Radiology. They were like almost, the faculty for all of them were academic people. They were trained in wonderful places. And so as a resident, I was being, you're trained by all of these people. You have to go down to pathology to review the slides. And we had wonderful pathologists. So I felt good where I was, and I felt like I would be able to accomplish anything I wanted to in medicine. So that was one of the things that I was most happy with. And then I was supposed to go to Boston for my training program in cardiology. The head of our Department of Medicine said, Mel, you should be going to Boston because that's where cardiology is. The reason why I didn't go is my mother had headaches, and there were mother's tension headaches, and I didn't know that. So I didn't go, and her headaches went away, and I was trained at Henry Ford Hospital after that.
Did you explore other hospitals before you made the decision to go to Sinai? I know you
Actually,
just
I
said
did.
Henry Ford.
Well, I didn't because I felt comfortable at Sinai. My friends were going to be going there. It was like a fraternal organization.
Was the fact that there were so many Jewish doctors, did that play into your decision?
I think it did. I don't think it was the doctors as much as the environment. Everything about it was what it made me feel comfortable.
Talk about the environment. What was it like, when
Well,
you
they had
came there?
rabbis. They had kosher kitchen. It was a very friendly hospital. It was small enough to be friendly and big enough to be good. And we worked very hard. The quality of care was very good, and our residents were all very comfortable with one another. There was a lot of kibitzing there. We had fun.
So the Jewish doctors, that was a dynamic. But what about the non-Jewish doctors who were there? Did
They
they
were
feel comfortable in the environment?
100%. Yeah, they were loyal to the hospital, and there was, in those days, those non-Jew, a lot of them were surgeons. The surgical group had a lot more than the medical. I was internal medicine, and it was the surgeons that had a much larger number of non-Jewish doctors. But I was very comfortable with everybody.
Now, did you experience any Jewish doctors who applied at other hospitals but came to Sinai because of the environment and because...
You're talking about attending physicians eventually?
Yeah.
Absolutely. There was they weren't comfortable at Sinai and at Harper, and there was very little going on at Beaumont. But a lot of them worked at Grace Hospital, and when Sinai became a very good, well-known hospital, a lot of them moved their practices from Grace or Mount Carmel to Sinai. And it was not surprising because it was a better hospital over time.
Were there intimate relationships between Sinai and other hospitals? You mentioned Henry Ford.
That wasn't intimate at all. That was more of a conflict.
Talk about that.
Well, the problem was that Henry Ford developed an HMO, and the HMO that they put together was part of the destruction of Sinai's opportunity, because they wouldn't allow Sinai physicians to practice within that health maintenance organization. And that then took a lot of the patients away from us. A lot of the patients were involved in that HMO. So the only thing that could happen is the Woodland Medical Group, which was one of the big forces, did get the opportunity to work with them because it was smart on that HMO and they got a captured audience, but it then diluted our capacity badly to retain our good doctors.
Was there any compatible relationships with some of the other hospitals in town? Or we were on
always,
an island?
Yeah, we were always, I don't want to say the enemy, but we were the competition.
What positions did you hold at Sinai through the years?
So when I got out of my training program, I was one of the few people that were trained for a couple of years, 2 years, in cardiology. I was trained in the heart catheterization was the second year. And that was a brand new thing. This was 1970. I was in training from 68 to 70. My training at Henry Ford was very, very good in heart catheterization and valvular heart disease and angiography to do bypasses.
That was just starting then, wasn't it?
That's my point. There was a fellow named Mason Sones who had just left and gone to the Cleveland Clinic a year or two before I got there. But that's who started the whole business. So the people that I was trained under there were very good at it because he was there at Henry Ford. And the people that trained me were really very, very good clinicians and very good in the cath lab. And the doctors at Sinai who were doing catheterizations saw one and did one. They were not prepared to do this, and we did not have the right equipment. None of it was appropriate, but it's what it was. That's all they had. So when I was trained, I was offered a lot of really good jobs. I'll never forget, one of them offered me $100,000, and this was 1970. It was insane. The average, my father-in-law at the time was making about $40,000 a year. He was one of the busiest doctors. And that was very attractive, but that's not what my brain said. No, I don't want to do that because I want to go back to Sinai. This wasn't a Sinai doctor; it was a Harper doctor, and and uh, and so, but Sinai had nothing to attract me other than that hospital. But along comes the idea that there's a guy named Adrian Kantrowitz who's going to be the head of surgery. And I had to make my commitment like 8 or 10 months before I would get a job. So I'm interviewing. But then they tell me there's a doctor from New York. Have you ever heard of him? I said, no. So I started reading about who he is. And he had done the second heart transplant in the world. He had this tool called the intra-aortic balloon pump, an assist device for heart shock. He had 150 dogs that were experimental. And at the time, it was really an attractive thing to think about. But I talked to my father, and he said, that doesn't matter to you. You don't want to do that kind of work. $100,000 is incredible. So I said no. After thinking about it and meeting Adrian Kantrowitz and meeting a few of his team and meeting the chairman of medicine, I said, I'm going to go there. And I made $25,000. But it was a lot of money then, too. And so what I did is I became the chief of cardiology. I recruited, became the chief of cardiology. What did they want that for? It's because they wanted a full-time person, and they wanted somebody to help expand the program, develop the cath lab, develop the ICU, the coronary care unit. I'm 31 years old, no experience in any of this stuff. But they were very smart, and they sent me around the country to meet other cath lab leads, other chiefs of cardiology, and that was what they wanted to do. And then they hired an incredibly good electrical engineer to help me develop, because cardiology is electronics, and we developed an academic program in electronics. There was one cardiologist who was really a very pleasant guy and a very bright guy. His name was Henry Green. Henry passed away not too long ago, but he was a scientist in electrical engineering. He wasn't, but he had a hobby. So we were able to, between this electrical engineer that we had hired him and Henry, we were able to develop one of the great, early on, one of the wonderful cardiac intensive care units. And that's what they wanted me to run, because I had the training for that, and we developed the cath labs. So that was the early time. And then the second year that I was there, I said, we need a fellowship, because the fellows will improve the environment. So of course they said, okay, recruit a fellow, and then recruit another fellow. And then I started with 1 a year, then it was 2 a year, then it was 3 a year. And we had then, over the next 5 to 8 years, we had one of the best training programs in cardiology in Michigan. The fellows would come from U of M to train with us. And our cardiologists became very important. All of our cardiologists became an important part of, because we were doing better, they stayed there. A lot of the internists went elsewhere, but our cardiologists were proud of what they were able to accomplish where we were. And our heart surgical program grew, and it was very good. So that was the environment I was able to be in.
All this costs money. How did you get the money for this?
In those days, I wasn't a fundraiser, but the Women's Guild gave us $300,000. And these women are the women that are selling things for $3, and they're volunteers. They raised $300,000 for the cath lab. So that's how we had the cath lab built.
So you just alluded to it, but I want you. It became a very innovative.
Oh, we were.
So talk about some of the things, the leading innovations that Sinai.
Right. So Adrian came. By the way, he didn't have a great reputation when he left. He didn't have a great reputation when he was there because he was a competitor. He was full-time. He was a heart surgeon. And the environment of heart surgery was there were volunteer attending physicians who did heart surgery, and then Adrian was full-time. And he wanted things done his way. He was the head of heart surgery. Well, the thoracic surgeons were not happy with this guy, and they didn't always agree. But I was part of Adrian's research team, and that really made me grow academically. It was through him that I gained a lot of experience in academics. I went to the meetings, I presented at the meetings because he and I were doing research together. I was his junior colleague. So that allowed me to mature and to get a better understanding of what was good and what was needed. And I met a lot of people around the country who were pioneers in their field. So it wasn't hard to begin to think about what you can do or should do when you have an Adrian Kantrowitz and his electrical engineers working with us, statisticians. We had a team of people. We had writers for the journals. So it was easy for me to swing into from just clinical to academics.
I was going to ask you, where did he go, and how did that
He stayed
change?
there and
How did
retired.
it change your position at the hospital?
Well, it was all good in relationship to, I mean, people were impressed with the programs and the development. So when you asked what you asked, the intra-aortic balloon pump was what he brought from New York, and there was research in it. It was a device that you put in the groin, and it helps the heart pump. It relieves the heart's pressure. There were only maybe 30 cases or 40 cases done in the country when he brought that device to us. And we were then a team. We were asked to come to California, to Cedar Sinai there, because one of the VIPs there. We flew there with our devices. We became the referral center for cardiology patients who were very sick, and we developed an assist device for chronic heart failure. Those were novel. Those are international. Adrian was an international specialist. He was rated one of the top 40 people who contributed to heart disease from 1900s to the 1980s. And he still has that reputation. So this assist device allowed us to begin to think, continuously think about it. So one of the things that I did is you had to monitor these patients who had artificial assist devices, including people that we were evaluating who were going to die because there was no transplant programs. So an assist device would keep them alive. But we needed to know how well the assist device was doing. So you had to catheterize them. Well, that was the early days. There were no catheters to do it in the ICU. You had to have a cath lab to put it in and take it out. Mm-hmm. Well, I took some sterilized polyethylene tubing, and I would put it into the vein, and without knowing where it was going, but it had to go to the heart because it was going from the vein, hoping that it would fly up into the pulmonary artery, and it did. And so we were able to measure the heart in those days. Then I asked our people to let me go out to California to meet a fellow named Jeremy Swan. Jeremy Swan was the one who invented the catheter that had a little balloon on its tip, so it would go up into the heart. If you inflate the balloon, it would have nowhere to go but the heart, up into the pulmonary artery. So we did that, and we developed our own tools. We developed one that allowed us to do cardiac outputs or measure the blood flow from the heart. That was one of the things we contributed to the development of being able to monitor the heart. We developed a new pacemaker where you could pace both chambers, the upper and lower chambers. Nobody had done that. We did that. Those were the two biggest ones, but then the artificial assist device that people would wear at home. And that was Adrian's device, and I was doing a lot of the research because somebody had to evaluate those patients. So I was the one that evaluated them. And it was in those days that we had extremely good reputation locally and nationally, because if you had heart failure or cardiogenic shock, weakened heart muscle, low blood pressure, the physicians, the cardiologists around southeastern Michigan and even northern Michigan would be sending their patients to us. And we had a dedicated unit. The hospital was capable of building a dedicated unit to do this clinical research. It was incredible. We had walls of monitors that were unique because our electrical engineers, who were biomedical engineers with Adrian's group, could design them and build them. That was a lot of what we did. And we also did a lot of initial work monitoring, or we had I was fortunate enough to bring in a couple of really good people with me who were clinician scientists. Both of them were from Europe. One of them was Dr. Weisschuk, Waldemar Weisschuk, and I was able to recruit him in 71 or 2 to work with me with Kantrowitz, because we needed to work on the dog models too. We had a dog lab, and Piero Foa at the time was an endocrinologist who developed the research program. A guy named Al Whitty was a physiologist, so they would help us. We had anesthesiologists, animal veterinarian anesthesiologist, put the dogs to sleep.
Were these all independent departments, or was it all part of the?
There was a research facility in the lower level, and anybody that wanted to, the surgeon could use it, we could use it, and we did a lot of work with ours, with Adrian, and a lot of work on our own as well. A radiologist, Phil Cascade, and I worked very closely together. But what I was getting at is this environment made us better clinically. It's people would say, how can you kill a dog? That experience was invaluable as to how these things work, and so that was part of the reason why we were able to publish, we were able to teach, we were able to have our residents participate in this, and that meant if you were a resident at U of M or Wayne State or Ohio State, you might hear about us and you might come to us because you wanted to do research as part of your clinical experience. And most of the hospitals didn't have anything like that. Mm-hmm. So that got us to an entirely different level.
Did the departments work together on projects?
Yeah, well, radiology was critically important for us. This Phil Cascade was part of our research group. He was the head of radiology. After several years, he became the head of radiology there, and so we would work very closely together.
Tell me about the culture at Sinai when you started there and when you departed there. How, if, and did it change?
Well, I was an employee of the hospital, and was very comfortable in that, particularly since the relationship with all the physicians was very good. Over time, I developed a better education program by having more faculty, full-time faculty. And as that grew, the hospital got better and better, because when you have full-time faculty, if a patient comes into the emergency room with a heart attack, the patient's taken care of immediately by somebody who's always there. So the environment improved the quality, but we also had specialists. When I recruited doctors, I did it because the academic centers had people who were very capable in a specific area, and I wanted us to be at the same level. So when I recruited young physicians to join me from our own program, fellows who trained with us, joined us, it was because I wanted somebody to do heart failure, or I wanted somebody to do electrophysiology. Heart failure is a weakened heart. Electrophysiology is the pacemakers and treating complex heart irregularities, and then angioplasties, and each one of and then cardiac rehabilitation. So I sent somebody to Montreal to help me develop cardiac rehab. I sent somebody to New York. Howard Fruman developed the electrophysiology. Valdemar Weisstick developed the interventional, the balloon angioplasties. And that's what the hospital allowed me to do as the chief of cardiology. And so we were able to improve the quality of care and have specialists. The other hospitals in Detroit did not have any of these things. We were the first to do all of these things. And it was an environment where everybody was in agreement because the hospital was getting this reputation. Over time, by the way, I should let you know that I was the chief of cardiology when I was a kid, but by the time in the mid-1980s, I was 45. And so I was maturing intellectually and as a person, and I was trying to create a good environment. And then there was some conflict, and I became the chairman of medicine as well, because the chairman of medicine was not adequate to help recruit good house staff, so they replaced him with Ernie Axelrod, whose name might have come up. Wonderful man, wonderful teacher, very, very pleasant, kind, and he became the chairman of medicine, and he was a hematologist. And he and I got along extremely well. He said, Mel, I don't know anything about the heart. You just tell me what you want and need, and we'll work together. So that's what we were able to do, and he was very supportive of everything we were doing. And I was supportive of all the other programs, because the heart overlaps with all the other programs, and so it was very good. And But then he had to retire. He was getting to the point where he had to retire. So they're going to recruit somebody else. And they couldn't recruit anybody that was of the stature that we would have wanted. And there were a few people in Detroit that were interested. And people said, if that guy becomes the chief, I'm not going to. So they came to me and said, Mel, what do you think about this guy? I said, I agree with them. I wouldn't stay either. So they said, well, what do you think? What do you mean, what I think? Would you want to be the chief of medicine too? I said, no. I mean, I got a full-time job in cardiology. But they convinced me, and they convinced me by making the offer that I would take off half my clinical load, and I can increase my academic time. And then I was able to personally recruit some incredibly good people to work in our division heads. In each area, I had a phenomenal guy named Bob Bloom. You probably, somebody must have talked about Bob. He was the program director, and incredible program director. So our residency improved dramatically with him. And we had just wonderful people working with us. But that created a bad environment. It created, instead of the environment where everybody was on the same team, when Henry Ford was pulling all those doctors and patients away and Beaumont was pulling them away, the idea that there was all these full-time physicians doing teaching and earning more money than they should, according to the private practitioners, there became a town and gown war.
So it's actually my next question. You're ahead of me.
Right. So that
Talk about that a little bit.
So the town and gown war happens everywhere. If they're a full-time faculty at a university hospital, which there very often are, they're often, there's also, the great majority of them have private practitioners, because the private practitioners are bringing in the community of patients, and it's keeping the hospital afloat. And they're very important, and they're also making the hospital stronger. An academic medical center can't live, most of them, without a family of clinicians who bring their patients to that hospital, different than the full-time people who have practices, but they're smaller practices, and they spend half their time or whatever percentage of their time teaching and doing research. So that's the academic medical center. Well, we had evolved into that, not being a university, but we had full-time people in anesthesia. We had full-time people in pathology. Why wouldn't you want to have full-time people in internal medicine for the same reasons? So it was very logical. It was done in most of the good hospitals. A lot of the Jewish hospitals around the country had that same type of atmosphere. But it was competitive then, because you're competing for the same population of patients. It was not a problem in the beginning because everybody was so busy. But when the insurance program started taking over with the HMO, and a lot of people started going to Henry Ford, and a lot of the doctors took their patients to Beaumont. Now we were getting less patients at Sinai, and so the primary care, the private cardiologists were getting concerned that their volumes were reducing, and there was competition, and they're looking to us, the full-time faculty, as the competition, realizing that it was a great environment for their patients, but there was an economic issue at the same time. So that's the town gown. The gown meaning the academic physicians, the town meaning the private practitioners. Every university hospital in the country had the same thing. And we weren't a university hospital, we were a community hospital. And it was owned by the Jewish community. So it created conflict. And there's nothing worse than Jewish people being angry at you and taking sides. And so that town and gown warfare made it very difficult for me to continue at Sinai the way I was enjoying my practice there. But I wasn't going to leave unless there was some crisis. And there was
Did
no
that cause in any way the sunsetting of the hospital this whole time?
It had already started. I was the chairman of medicine when the sunsetting had begun, and the idea of potentially merging with Henry Ford or merging with University of Michigan or getting better relationship with Wayne State and maybe merging with them. All that was being discussed when I was the chairman of medicine.
How'd you feel about that?
I knew we had to. We had to merge with somebody or we're going to die. But I was pretty convinced that it was a good idea. I had no problem not being the chief of everything. I didn't even want that. I was always trying to recruit a cardiologist to run cardiology so that I could do the chair of medicine or recruit it. I didn't want those jobs. But that was a time when things were slow and bad, and there was nothing that you could do. We lost our research building. The research building was closed and bought by, our whole research program went to Wayne State. So I was there without that opportunity for our team to do as much. And so it wasn't as good a job. And then the town-gown conflict, and it was difficult to manage issues. The quality of care was good, and you spent a lot of time, and you didn't get any support. So I guess what I was saying is by a year or two after I became the chair of medicine, it was like I had a target on my back. And if things were going wrong, it must be my fault. But they brought all these people from New York, you know, the consultants came in to see what should be done with the hospital. So they would always be asking me because I was running the biggest department. And I was supporting the idea that we should merge, that we should be bought out or merge because we can't survive indefinitely. Our location wasn't good.
Demographics had a lot to do with it.
Our location was poor. We had always talked about a hospital in West Bloomfield or somewhere.
Why do you think that didn't work?
It's an easy answer. Max Fisher decided when the things were we were thinking about it, he had decided to build the Fisher wing so we would improve the hospital, and that would keep it there, that we wouldn't have to be thinking about moving. And that was true, it did, and that was in the late it was like the Fisher wing was built in the 1970s. But it kept things going, and it was beautiful, and private rooms and semi-private. We had wards on the internal medicine side, but that's what it was, and everything was fine. But as things got worse, the idea of another hospital became much more important. And it looked like it was going to work out, particularly if we couldn't get relationships with these other hospitals. We'd have to think about that more seriously. But Max vetoed it. Somewhere in the coffee lounge somewhere in Detroit, he was talking to everybody, and he spoke out and said, no, we're not going to do this because we'll be abandoning Detroit. And if we abandon Detroit, the Jewish community will have much more difficulty, and anti-Semitism will be abound. And so that's why it was stopped. And they knew about Henry Ford. There was actually a possible relationship that we would build this hospital together. And that made imminent sense. It also made imminent sense that we would sell or merge and take away the load from the Jewish community, which it was costing a lot of money with the donations and so on. It was taking money from other potential options. And I knew we weren't going to survive as a solo hospital. It was going to be impossible because of the insurance distribution, and the other hospitals became better. Providence became much better. They developed a heart program. Beaumont already they recruited a guy named Bill O'Neill, who was in Ann Arbor. I had already tried to recruit him, and he went to Beaumont. Why? First of all, he wasn't Jewish. Secondly, Beaumont was much bigger than we were, and they had some very good people too. So how are we going to survive?
Didn't some of our doctors also go to Beaumont?
Well, that's what I was saying. In the mid-1980s or the early 1980s, Beaumont started to do better. And so they started to go out there because their patients wanted to go out there. Sinai was in the city. Emergency EMS from Oakland County wasn't coming to us. They stopped at 8 Mile Road. We didn't have a relationship with EMS. And so that was another reason why Providence did better and Beaumont did better and Botsford did better, because that EMS system took a lot of our patients. So you can see how while we were great in certain areas, the patients were the most important part of this, and we didn't have access to the patients because of the insurance, because the physicians were leaving, and our location. 3 major reasons for not doing well. And the handwriting was on the wall. If we didn't go out to West Bloomfield, it wasn't going to work. And
do you think it could have worked if?
No.
How come?
We couldn't afford it. Well, let's put it the other way. Could it have worked if we had $100 million? Maybe. And then was it going to survive? What's going to happen after that? Nothing lasts forever. Right. So if you look at what are we going to do to replace it 30 years? Where's the Jewish population going to be then? It would be too big a gamble. So I wasn't in favor of but I left. But the hospital was still going, and it lasted 6 more years. Yeah. But I knew the handwriting, I knew it wasn't going to last.
What was the atmosphere there, Mel?
It was very difficult. Nobody was happy. It wasn't us anymore. It was just that nobody was happy with the administration. The Jewish administration was kicked out. They brought in the consultants to run the hospital. That was a terrible thing, because Sid Pimer, Julian Priver were the two people that really developed the hospital from nothing, and I knew them well because I was there in 1970, and I respected both of them. Julian was more of a formal guy. Sid was a buddy. I mean a buddy with the doctors, and both of them had very important contributions. Julian was intimately related and intellectually with the very wealthy people. Anybody that had a lot of money wanted to be on the board of Sinai Hospital. It was a very prestigious thing to do, and it was an interesting thing for them to do. And so there were brilliant people, very philanthropic on the board. And that made it easy. But those same people were attracted to other hospitals. Beaumont started to recruit our very community-oriented, health-oriented people who trusted the hospital, trusted Sinai. Some of them were going to Beaumont for their care. And so all of the things that we had were diluted. And yeah.
So the sale of the hospital, I don't want to put words into your mouth, you were comfortable with that?
Well, I wasn't comfortable. I was comfortable because I had been gone for 7 or 8 years. But I want to tell you something. I couldn't have thought better of it. I was so glad that whoever did it, I know Bobby Sosnick, who was a patient and friend of mine, was instrumental, and he talked to me a little bit about it, and I said, Bobby, if you can do that and get $30 million, it's phenomenal, because we're going to be losing money every year, and the Jewish community is going to be stuck. So don't put yourself in that. I mean, don't put us. It wasn't me anymore. I was gone by then. But I knew what was going on. I had no idea that they would get $65 million to spend in health care for the Jewish community, and also help support the health care of people who were in that environment who couldn't afford it. And I mean, I thought that was just phenomenal, because it was going to do everything. It was going to help the Jewish community. It was going to help the community at large. We're not abandoning the city of Detroit. We'll be continuing as a hospital, if it's possible, and Jewish physicians will still have. There was no anti-Semitic by then. The Jewish physicians had
absorbed.
Jobs.
Yeah.
That was never a problem. So when it all happened, I thought it was phenomenal, and I was so happy for the community.
Are you happy with? Now didn't you serve on the foundation board for?
Not then. I joined that about 4 or 5 years ago.
So then I'm going to ask that question. Are you pleased with the work of the foundation and what they've been doing for the Jewish community and the general community?
Wonderful. Absolutely. The foundation was something I didn't know much about. When I left to go to Ann Arbor, that was 1991, my career was gone. And I had all these responsibilities there, so I had very little, if anything, to do with Sinai. I would come back to give lectures or something like that. But so I was at a distance, and I didn't know much about what was going on. And I knew they were having problems recruiting people to replace people, and there was nobody happy. So when it happened, and I was asked what did I think, I would tell people, this hospital wasn't going to survive. It's not going to survive and lose money for the Jewish community. And it's not going to be able to compete and be the hospital that it is today. And by that time, we already had the hospital out in
Huron Valley?
In Huron Valley. In Huron Valley, Sinai was going, but it wasn't going to be Sinai Hospital. It wasn't going to be that wonderful, high-level institution that people would want to go to. First of all, it was small. Secondly, it was a general community hospital, and they were never going to get the kind of things that Jewish community, the best of this person, the best of that person, they're not going to be practicing out there. So I knew that wasn't going to make it from our point of view. And And I didn't think the merger of Sinai with Mount Carmel would ever make anything, because we were the one that was going to close. And so what is it? What's the point? So all of that meant very little to me, other than getting that kind of money to be able to keep supporting what we wanted to do. And so that money, with the Federation allocating a significant amount of that to this group, I can't remember the group's name, but it has to do with the hospital's resources, and it's run by a very bright lady whose name also escapes me. And they then helped fund a lot of things, a lot of programs that developed in the Jewish community, replaced the need for the hospital to be there. And I think that was phenomenal. Is that what you're talking about?
Yeah.
Oh, I thought you were talking about the physician foundation.
No. We're talking about...
Oh, so that foundation, I'm sorry. Yes, they got that money, and they've done an incredibly good job. And I was helping, before I left Sinai, I was in the community doing a lot of things on various committees. And that's exactly what we needed, but we didn't have any money to do it. When that became an opportunity, having sold the hospital, some very bright people were on that committee. And I noticed, I knew what they were doing, and I thought it was wonderful. I never served with them, but I did apply to them for a grant, and they gave me my first 2 years of grants for Project Healthy Community. Yeah.
Just take a step back. What was the thing that you liked most about working at Sinai when you were there?
In the early days, it was how, I mentioned this a little while ago, in the early days, it was how good our support system was. That if you had a sick patient, you didn't have to send them to Ann Arbor for an operation. It could be done right there, our radiologists, pathologists, and so on. And so that's what I liked most about it. And I liked also how good our internists were, and the surgeons. They were, and I told you this already, when I went out to U of M later on, I realized that those doctors, their primary care doctors, weren't as good as ours. And I was very proud of that. And then I was most proud of the faculty that I was able to recruit and help them grow, and through their own research programs. Being a mentor was something that I've enjoyed all my life. And that's why I went to Ann Arbor. And I was always interested in mentoring the young students. Mm-hmm. That's what I enjoyed the most, the students, the residents, the fellows, and the environment that it created.
Did anything disappoint you in your time at Sinai?
The town gown was, I'm what my mother would call a sweet man. And I didn't want conflict. And it was difficult, because I couldn't play the game of publicly letting people know that I'm dissatisfied or blame them for something. I couldn't do that, but they had the opportunity to do it. You know, in the coffee lounge, it was they're talking, this is the private group, they're in the coffee lounge, and I don't walk in the coffee lounge, I'm busy all day long. So I have a cup of coffee and leave, but then there was so much bad talk about, it wasn't just us, it was the full-time faculty in surgery too, I would guess.
Politics.
It's politics, and it was nasty.
Yeah.
So that's what I hate.
Now, you've mentioned through this very pleasant for me interview a number of people who had influence on you. Is there anyone that you missed that you want to acknowledge in this little discussion we're having?
Well, I told you about Adrian.
Right.
And I told you about Phil Cascade.
Right.
I would say it was the heads of all the departments. We worked very closely together. And it's hard not to name, all of them.
Okay.
Because they were all, Hugh Beckman, for example, was really a very good contributor. Milt Goldrath, an OBGYN, and I had a good relationship. He asked me to be on the abortion committee. And I said, what do you mean? What do you want me to do? He said, we have to have somebody approve that this is legitimate, and you're not an OB, and you're going to be the veto, or yes or no. And I said, well, what does this mean? He said, well, 20 weeks is where you have to make the decision. I said, so that means a fetus that's already looks like a human being, I got to make the decision? So he said, Mel, you'll know what I'm talking about when these things come up. So But Milt and I got along very well. And when I told him, when he heard that I was leaving to go to Ann Arbor, he came to my office and he said, "Let's talk." I said, "What do you want to talk about?" He said, "You're making the wrong decision. You should stay here. It's no big deal to go to Ann Arbor. It's the same thing. It's just, you're in a good position." I said, "Milt, I'm not. I'm not happy any longer. I got to do something different." And then he supported me. And that was one of the very nice things. All of the people that, when I left, they were very happy that I had been there, and most of them were very disappointed. And the funniest thing is, some of those cardiologists that I was telling you were conflicting with me were referring me patients to Ann Arbor.
So that must have made you feel good.
Had good. It was one of the best things that that it wasn't me. It was the position I was in, that I was trapped. Somebody had to do what I did, and it wasn't comfortable. But it wasn't a collegial concerning about our health professional aspect.
So just a word before we conclude this. A word about your family, your wife, your kids.
Oh.
Might as well get them on record.
First of all, I married a wonderful woman who was loving and who was loved by everybody, and she allowed me to do what I did. Without Diane, I would not have been able to do what I did. And she enjoyed it, and she grew with all this. She grew in herself, professionally. She wasn't a working woman, but she was very, very active and enjoyed the activities with the hospital too. But what I wanted to mention was when I was a resident, I had to make a few bucks because we were paid $4,500. Actually, we were paid $3,000, but we got an additional $1,200 or $1,500 because we were married. And I actually had kids when I was in medical school. Nobody had kids. Nobody was even married. But I got married when I was 21, and just going on 22. She was 21. And my son, Mark, who's a wonderful guy and an attorney, and so proud of him and my daughter. But anyway, Mark was born when I was in my second year of medical school, and Karen in my third year. And it wasn't easy to go through medical school. Having two kids was really difficult because I took care of the kids. So I had my study pants. I had a pair of blue jeans that I would be studying, and the kids would have to be quiet. It wasn't easy. We were in an apartment, and but Diane kept it all going. And then I raised my family at Sinai, because when I was a resident, I was on call. Diane would bring the kids for dinner. And
were you in the apartments there?
No, we had a small apartment. But that was when you said what's Sinai like with a family, so that was part of the family. All of the staff in the kitchen, the cafeteria, knew my family, and these were African American women who lived in the community, and they all they knew me, and because I had worked there in the summers, I had jobs there in the summers. I forgot to tell you that. That was part of being a family, and why I went to Sinai as a resident was that I worked during the summer as a scrub nurse or an orderly. So, and that's how I learned. That's how I met Mr. Pimer and all the nurses. But what I'm getting at is the hospital became a place where we lived. She'd bring the kids to dinner every night. I was on call, and that was every third or fourth night. So all the crews in the kitchen, the cafeteria, knew my kids. And when I went on rounds in the hospital, I'd have the kids in the lounge, and they would meet everybody.
That's great.
It was all good.
We miss anything?
I miss everything, but only the memories. I don't want to go back in that part of my life. U of M has been very good to me, and I've been good to U of M.
Good. Thank you, Mel.